Yeah, so I think adjuvant pembro and kidney cancer, the story of adjuvant immune therapy and kidney cancer is a little complicated. Adjuvant KEYNOTE has shown DFS benefit, right? It was approved on that basis in a follow-up, but now we have overall survival benefit. And yet it is a big deal. We've not been able to show that with adjuvant immune therapy, broadly speaking, and certainly never in kidney cancer before. One of the confusing points is that we have 3 other adjuvant trials that were negative, like flatly negative for DFS and then obviously OS. So we've talked over the last year or so about these discrepancies and why, but if you just sort of look at the KEYNOTE data by itself, it's very clean. The DFS curve split and stay split, the OS curve stays split. Many to most people got subsequent therapy. We don't know all the details about subsequent therapy and timing and type, and they also had a lot of local salvage therapy of surgery and radiation, which is a bit unusual. The percentage was a little high. So there's always things you can pick apart, as we should, right? We should be critical about data when we're applying it to patients. But back to your question, yeah, I think it's really important data for the field, and I think sort of, sets the framework for where we go in this space moving forward. I think it's a couple things. One is, yes, when you talk to patients, before you said, I don't know that giving you this drug will make you live longer. But now you can say that, yeah, on average, patients who get this drug in this setting live longer than patients who don't. How much that will move the needle for individual patients or docs, I don't know. I don't think it'll be the case where it moves it a huge amount, where somebody who just didn't give the drug now gives it to everybody. I think for everybody, it'll sort of move the needle where they either extend the risk groupings of patients they give it to, or give it a little more freely, or, we all influence patient decisions, right? When we're talking to patients, how the doctor speaks to them will influence their decisions, some more than others. So perhaps it's, going to be used in a little, or suggested in a little more favorable language. So I do think it will result in more use, in the community, in the, high-risk kidney cancer community in general. Well, now it establishes pembro as a standard of care in this setting. So it's something to build on. Merck's already accruing a trial of pembro plus belzutifan versus pembro in this setting. Whether belzutifan's the right partner in this setting, I have my personal doubts of, but it's at least an example of pembro now plus drug X versus pembro. And you can imagine we're going to see a lot of those studies. The vaccine study you alluded to there's some melanoma data, phase 2, but randomized and looked pretty good, and now is going to be applied to kidney cancer. So my personal belief is that we'll make advances by stacking immune therapies in this setting. So pembro plus immune modulator A, maybe plus immune modulator B, and we'll start to cure more patients, and that's really what we want, right? To cure more patients. The balance on that is, even in a high-risk setting, you're treating a lot of patients who don't have cancer, right? High-risk kidney cancer, even at 40 or 50% risk of recurrence, means that most patients won't recur. You can only harm those patients with therapy. And I think that's why it's different in this setting than a metastatic setting. Metastatic setting, the doc and the patient are much more willing to put up with toxicity. In the adjuvant setting, I think that you're less willing, and that's what gives patients and I think providers a bit of pause. Yeah, good question, right? So if we had tools to select, number one, patients who are going to recur, circulating tumor DNA and or other mechanisms we don't really have in RCC, and or patients who are going to respond to therapy, which we clearly don't have despite years of looking in the metastatic setting. Then you could not treat those patients who aren't going to recur, right, and not cause them harm, and focus the potentially toxic treatment on not only patients who recur, but again, patients who respond. I wish we were closer to having those tools, and everybody at this meeting is, working hard to develop them, but we just don't have them. They're not ready, for prime time in the clinic. So hopefully, as we move on in the years, we'll develop them, but I've been around 2 decades and we haven't developed them yet. So we'll see. We're all hopeful, and there's new tools, but nothing yet. I think we all believe that for any drug, Belzu or any drug, any setting, that we all care that we're making patients better and not worse, right? So if we're only shrinking tumors a little bit or controlling their disease a little bit longer, but the drugs are super toxic, none of us would really want to do that, and patients don't want to receive it. So the concept of quality of life is that let's make sure, that the treatment's not worse than the disease, right? The tricky part, and I think Tom highlighted it this morning, is that our tools to measure that are super imprecise. They're old questionnaires. They don't measure the right thing. They were developed in a different era. The way patients fill them out is imperfect. The way we capture data is imperfect. So there's a lot of imperfection of how we do that. What Tom presented was basically showing, that belzutifan is a really well-tolerated drug that does not lead to decrements, substantial decrements in quality of life. And everolimus is a little more toxic and a little more impact on quality of life. So to me, this was a clean look at quality of life because it was one drug versus one drug as opposed to combinations. And it's believable, right? I've given plenty of both of these drugs, and belzutifan is definitely a better tolerated drug. And with, I believe, minimal impact on quality of life, having given it to probably dozens of patients now. But the tools to measure that are still imprecise. And we as a field, not just kidney cancer, but all of solid tumor oncology, need to do a better job of developing those tools so that we can speak with more confidence to patients that, yes, we're actually making your life better and not worse. And hopefully longer. We don't know that with belzutifan yet, but hopefully, every medical decision I make, I ask myself, am I making this patient live better or longer, or both? Right? The better part is where quality of life comes in, but our ability to measure that is limited.